Good afternoon, everyone. We would like to get started now, please. Thank you. Sorry. So welcome. My name is Sue Robertson. I am the program coordinator at the Adult CF Center of Tampa General Hospital, and this is my co-chair, Cheryl Kushner.
Good afternoon. Good afternoon, everybody, and we would like to welcome you all, including all of you joining us virtually, to Symposium 3 entitled Golden Girls Care Considerations for the Aging CF Female. And honestly, how exciting is that? So, as you know, improved CF therapeutics has significantly increased life expectancy for people with CF. The demography is changing, bringing new challenges in caring for women with cystic fibrosis as they age. Today, we will explore a variety of topics facing women with cystic fibrosis. The symposium will cover a variety of topics that impact women with CF as they grow older and face a variety of changes in their physical and emotional health. First, we will open with a discussion on shifting the focus from resilience, stress, and coping to agency empowerment and expertise in the context of embodied knowledge in chronic illness self-management. Next, we will hear about the impact of aging and menopause in females with cystic fibrosis. This is followed by an overview of risks and drug interactions associated with common medications used to treat peri-menopausal symptoms. We will end with a CF community member who will share her experiences as a person aging and thriving with cystic fibrosis and offer guidance to clinicians about best care approaches for this special population. We really do encourage you to ask questions. There are mics on the phone available to you if you want to stand up, and you can also do them on the app. To do this, open your mobile phone, locate our session S03 on the app, click Q&A button, locate it on the bottom, and you can ask your questions. We will work really hard to get to all your questions if time allows. We plan on having Q&A after each speaker, and then if time allows, we'll do it again at the end.
I'm actually up here having a hot flash, so I'm feeling this whole thing so much right now. It's great. I am pleased to introduce our first speaker. Sandy Suffian is a full professor in the University of Illinois Chicago's Department of Medical Education, the Department of Disability and Human Development, and the Department of History. Her research interests include studying sexual and reproductive health issues for women with cystic fibrosis. Dr. Suffian co-founded the Cystic Fibrosis Reproductive and Sexual Health Collaborative, otherwise known as CFRESH, a really cool program, a partnership with the CF female community to identify research priorities and questions about SRH and CF. She was a co-PI for the menstrual study that examined CF symptoms across the menstrual cycle, which she will present today. She was also the PI for a PCORI Engagement Award that applied the CFRESH framework for devising patient-driven research questions in the breast cancer community. She was a fellow of the Menopause Society and now a Patrick Nash Fellow on Aging with CF from the CF Research Institute. She has published 3 books, numerous articles, and several co-op-eds. Go for it, Sandy. Thank you.
Thank you so much, Suzanne. Okay, so I am so sorry. I first want to say I'm so sorry that I can't be with all of you in Boston for the conference. I'm missing everyone and wish I could be there. I want to welcome those of you who are streaming this session. I think you're going to be in for a big treat. I am going to present today on embodied knowledge and the CF menstrual link. And if you have no clue what that means, don't worry. I will be explaining it throughout the rest of the talk. I have no disclosures to report. And during this talk, I'm going to give an overview of a study my colleagues and I conducted called the Menstrual Symptom Tracking to Understand and Assess Women Living with CF, or menstrual for short. I'm then going to briefly describe the concept of embodied knowledge and how we utilize this concept in our qualitative analysis. Next, I will present our study findings about cisgender women with CF's embodied knowledge and the CF menstrual link. From now on, I'm going to refer to these cisgender women, our participants, as just women, so you should know that they are cisgender. Finally, I will discuss the implications of our study finding for research and clinical care. Okay, so we all know that the vast majority of adult women with CF now experience menstruation. 25% report that their CF symptoms worsen with their menstrual cycle. We also know from the work of Sweezy, Chortamal, Jane, Johannesson, and others that there is a disparity between males and females with CF in mortality and morbidity, that estrogen impacts the conversion of Pseudomonas to its more virulent mucoid form, and that lung function and inflammatory lung biomarkers fluctuate during the menstrual cycle. But there aren't many studies that explore how reproductive age women with CF manage their worsened symptoms and how they experience this time in their life. So to contribute to this science, my colleagues and I conducted a pilot study funded by the CF Foundation between 2020 and 2023 to explore whether cisgender women with CF experience fluctuations in their CF symptoms during their menstrual cycle. And if women did experience those fluctuations, we wanted to know which CF symptoms they reported worsened, how severe they got when they experienced those worsened symptoms. That is, which phase in the menstrual cycle they experienced the symptoms. We also wanted to investigate how women made sense of their menstruation experience, including which strategies they used to ease any menstrual-related CF symptoms. We knew from our patient engagement work that gaining a better understanding of hormones, menstruation, and CF was a priority for women in the CF community. Our mixed method study explored the menstrual cyclicity of CF symptoms by having 72 participants track 22 CF symptoms across 4 menstrual cycles on a customized period tracking app. The CF symptoms we had our participants track included pulmonary, sinus, GI, and rheumatological symptoms. And the app we used also had general menstruation symptoms on it, so women could track those. But our team had a particular interest in investigating CF symptoms. The start of our study, it happened, corresponded with the widespread launch of Trikafta, and 89% of our participants were on modulators. So then the next phase in our study was the interview phase, which is the phase I'm going to be focusing on today. We conducted semi-structured interviews with a subset of 20 participants, averaging 45 to 90 minutes. And we engaged participants in discussions about whether they had cyclical CF symptoms, and if so, how they interpreted them. We applied a constructivist grounded theory approach to analyze our interview data and used Atlas TI to code and analyze the interview transcripts. We also used the philosophical and social science literature, and that informed our analysis and write-up, including work from critical phenomenology, body theory, sociology of impairment, critical disability studies, and digitized embodiment. Okay, so now you may be thinking, what is all this embodiment stuff that Sandy's talking about? Hopefully this slide and the next ones will help clarify things. So embodied knowledge was the central concept we utilized from the scholarship I just mentioned to interpret our data. Scholars' ideas about embodiment and embodied knowledge draw from phenomenologist Merleau-Ponty's notion that the body is the basis of human subjectivity and central to what he calls being in the world. Scholars Laura Ellingson and Anna Harris define embodied knowledge as grounded in, emerging from, quote, visceral, felt, or enlivened bodily experience, end quote. So basically, this means that embodied knowledge is grounded in and emerges from physical, affective, and sensory knowledge and experience, and that this shapes how individuals see and navigate their worlds. We identified 3 interrelated processes that occur when women experience menstrual-related CF symptoms. We found that these processes capture how women with CF navigate their illness, identity, and quality of life. The first process is that through digital tracking, that was the first part of our study, the digital tracking phase, and through that act of digitally tracking their symptoms, women produced embodied knowledge about the CF menstrual link. This intervention made participants even more aware of bodily changes than they already are. And we know that people with CF already are very attuned to monitoring every little thing that goes on with their body. And so, but with the digital tracking, these participants became even more attuned to these changes. Our participants realized that there was a relationship between their symptoms and their cycle, and that is what we call the CF menstrual link. The second process is that women apply this knowledge to manage their lives when they experience these worsened CF symptoms. Third process is that by producing and applying embodied knowledge, women in turn cultivate a distinct self-understanding as menstruating women with CF. So in the next few slides, I'm going to describe each of these processes in more depth. So first, tracking helped women notice symptom patterns. Most women noticed when CF symptoms got worse, when they worsened in the cycle, and how severe they got. This attunement to patterns allowed women to understand why, not just that it was happening, but why their symptoms got worse and then resolved every month. By recognizing that cause and effect with their menstrual cycle, they solidified the link between CF symptoms and menstruation. For instance, one participant said that before tracking, she noticed she had mood swings and worsened lung and sinus congestion, and also GI symptoms every month. But she thought about these symptoms as totally separate, with no root cause. After tracking, however, during her interview, she commented that tracking, quote, helped put all these things together as a whole. It framed everything into this nice little picture. All of this makes so much sense now. Now, most participants reported that exacerbated menstrual-related CF symptoms hindered their ability to contribute to family, work, and self-care. However, once women specifically noticed the timing of their menstrual-related CF symptoms, they felt that they could predict what would happen in the next cycle and adjust their routines. Thus, they used the embodied knowledge they gleaned from tracking to inform and tailor effective self-management strategies. And these strategies tried to ease the impairment effects of their symptoms and improve their quality of life. A key theme that surfaced in our interviews was bodily control. Interviewees felt that menstrual-related CF symptoms challenged their ability to exert control over their bodies. Most women reported wanting to gain better control over their cyclical symptoms, physical, emotional, and relational aspects, and they believed that having more bodily control would improve their quality of life. So when asked which part of their quality of life would improve if their cyclical symptoms were alleviated, one participant answered, quote, everything would be, like astronomically better. Mental health, physical health, my relationship, my family, literally everything. To help alleviate the disruptive impact of their symptoms, women applied their embodied knowledge to devise many, many creative strategies. And the list of strategies interviewees shared shows just how resourceful they are in managing their symptoms. These strategies are adaptable and smart and set clear boundaries around what a participant can or can't do. We found that women created 4 types of strategies. The first was those meant to mitigate symptoms. The second were those that introduced self-care. The third were those that adjusted women's schedules or routines. And the fourth were those that managed women's environments. Strategies to ease symptoms included increasing the frequency of nebulizer treatments or puffers or upping their airway clearance. Participants also performed extra nasal rinses or used a humidifier more often for worsened congestion. And some women even scheduled their PFT to coincide with the end of their period when their symptoms resolved in order to optimize their scores. For GI symptoms, they increased their dose of enzymes, took stool softeners, or used a heating pad to ease their symptoms. Examples of self-care strategies included taking short walks or long baths, altering their exercise routines, napping, or spending time with animals. And becoming aware of the timing in their cycle of their symptoms when they got worse helped women create proactive strategies regarding their schedules and routines. Participants predicted when they would have worsened symptoms and made the appropriate scheduling changes. Many participants, for instance, avoided making plans right before or during their period when they reported their symptoms got worse. Others noted they were more careful about expending energy when their symptoms flared. They weighed the costs and benefits of their activities and often asked for help from family or friends to take on those tasks they felt they couldn't do when they had their worsened symptoms. And finally, participants created strategies that managed their environments. They kept water on hand, carried extra pancreatic enzymes in their bags, or worked from home to manage their cyclical fatigue or GI symptoms. Self-management strategies came from a variety of sources, including experience, trial and error, reading, doctors' recommendations, and social networks, especially within the CF community. Participants used CF websites, Facebook groups, and other social media groups to access ideas for numerous strategies. Now, producing and applying embodied knowledge about the CF menstrual link helped women cultivate a deeper understanding of themselves as reproductive age women with CF. We found that gender and disease identity, those two identities, are central components of women's selfhood. Moreover, we learned that menstruating women with CF feel that they have, as one participant commented, quote, a unique understanding of being a woman, end quote. One way the participants cultivated self-understanding was by situating themselves as members of the CF community. Networks, relationships, and communal bonds help participants navigate menstrual experience and provided much needed support. Women engage in collective forms of care by sharing knowledge with other women with CF and gaining information about the CF menstrual link, the experiences and strategies that other people use. And one participant expressed this sentiment remarking, quote, we are all in this together, end quote. Another way participants discussed their sense of self as reproductive age women with CF was by making comparisons to others with CF. One participant pointed out, for instance, that, quote, guys with CF just don't have to go through this, end quote. Participants also made comparisons to able-bodied women. For example, an interviewee pointed out, quote, you're constantly aware of things. You know your body better because of it. You can see how people who don't have as many issues as me may not be able to tell exactly what's wrong with their body, end quote. And comparisons to non-CF peers highlighted a difference in bodily awareness and centered around the themes of normality, body image, and beauty. A third participant commented, quote, I would love to have the hips that all women have. But at the end of the day, so long as my lungs are happy, I'm not going to be what everyone else will be. So I will just make up my own definitions, my own forms of beauty, end quote. And overlaying these comparisons were participants' recognition that modulator use has caused them to reappraise their expectations about their bodies, their opportunities, and relationships. And our interviewees grappled with these identity questions and identity shifts, while also imparting to us that their menstrual-related CF symptoms changed with modulator use. And I'm happy to talk more about this during the Q&A, if you're interested. So overall, our qualitative analysis showed that cisgender women with CF produce critical and distinct forms of embodied knowledge during their reproductive years, and that this knowledge shapes their illness experience, their disease management, overall health, quality of life, and self-identity. And on this final slide, I just want to highlight two implications of these findings. First, they suggest, among other things, that we should consider rethinking the concept and measurement of quality of life to include embodied knowledge as a domain, for instance, in the CFQR. Being acutely aware of changes in one's bodies and symptoms, when and why they occur, has real implications for patients' quality of life, because it empowers that person to act upon the knowledge in preemptive or concurrent ways. Because embodied knowledge is a key part of a patient's being in the world, navigating the world, it can influence how that person assesses their quality of life. And this is a point I hope that can help frame our discussion today about females aging with CF. It can possibly apply to other aspects of female aging that my colleagues on this panel will discuss. Just maybe. And finally, I want to suggest that the processes I described can help inform patient-centered care because they reveal the importance of taking seriously patients' experiences of their bodies and their agency in optimizing their health and well-being. And on this point, I'm going to finish by leaving you with a quote from one of our participants. Quote, I feel that it's important as a menstruating woman to let somebody on my CF team know that I've experienced a certain increase in certain symptoms around my period. Not because I need anything from the team, but for them to be aware and educated about what other women who they are seeing are experiencing, those that may be starting menstruation or who are already menstruating. So those experiences is what this participant wanted to relay to their CF team. And with that, I want to thank the participants in this study, in the menstrual study, and all of my wonderful collaborators listed here. Thank you so much.
So now we have some time for questions. If anybody has any and would like to come up to the podium. The microphone. I mean, the microphone.
We can't see you, just letting you know we can't see you, so please just speak up.
I was just wondering, have you seen any correlation in this number?
We hear you, though.
You can hear.
Sandy, can you hear her?
Can you hear her?
Can you just repeat not the speaker, but Suzanne, can you repeat the question? That might be better.
Did you hear
Yeah,
that?
so the attendee wanted to know if women noticed if they were on OCPs or any other form of hormonal contraception if their symptoms changed, like got better, I'm assuming is what you're asking? Some of them did say that, yes. Some of them did say that. Especially if it was, actually we required people to have a monthly bleed, so we didn't accept participants who, it was part of the exclusion criteria that you couldn't be on OCPs like without the placebos. So we wanted people to have a menstrual bleed. But we did, yeah. But some of them did say that their symptoms got a little better. I should say also about modulator use, we found really interestingly in the interviews, but also in the quantitative data, that women on modulators, which was the vast majority of the people in our study, did talk about like this before and after. So before Trikafta, my symptoms were horrific. I couldn't move. I couldn't do anything during certain points in my cycle, especially in terms of pulmonary and sinus congestion. And then after modulator use, what we found was that most of the symptoms turned into GI symptoms. So people really reported more GI symptoms than their pulmonary symptoms, although people still did report pulmonary symptoms. It just kind of shifted what the majority were experiencing. Which makes sense, right? Because you're not coughing as much or whatever, so it might be much harder to see a difference or feel a difference. But GI symptoms, people noticed.
Are there any other questions out there? If not, we will shift and we will go on to speaker number 2. Raksha Jain is a professor of pulmonary and critical care medicine and director of adult cystic fibrosis and bronchiectasis program at the University of Texas Southwestern Medical Center. She has a longstanding interest in women's health research and is chair of the Cystic Fibrosis Foundation-sponsored Sharing, Sexual Health, Reproduction, and Gender Research Working Group. Welcome, Raksha.
Thank you. Okay, thanks for having me today. I'm really pleased to be talking about this topic, which I think would not have been a topic many years ago. And I think you'll find that we have much to learn. So my goal today is really to give you a broad overview of menopause and the little that we know about menopause in the setting of CF. These are my disclosures, none of which are related to the topic today. So just to really set the stage, I think what we're seeing as people with CF get older and older is a balancing of their symptoms, and of those symptoms, what are related to CF and what are not related to CF, and how do we manage those? And I know I often hear some of my particularly female patients anywhere between the age of their late 30s to early 50s describe things including irritability, difficulty sleeping, they experience rapid bone loss, they have pelvic dysfunction and urinary incontinence, and even an exacerbation of depression and cognitive disorders. And what I think they really ask, and what I ask as a provider too, is it their age or is it CF? And what of this can we help them with? So I don't have answers to all of these today, but I at least want to set the stage for some of this. So first of all, just to broadly define what is menopause. So the true definition of menopause is going 12 months without having a period or a menstrual cycle. But this can really expand. This can go across many phases of a peri-menopausal and a menopause phase. And that phase, particularly of perimenopause, can last anywhere from 7 to 14 years. So it's a real struggle for people, particularly in their late 30s, to wonder, am I experiencing perimenopause symptoms? What is this that I'm having? But I think the reason some of this is particularly challenging for females and not as much for males, you'll see in a second, is the dramatic change in hormones that occur. So this is just a pictorial of some of the changes that occur in hormones in females in adulthood and as they get older. So for example, you can see in the orange and blue colors that estrogen and progesterone fairly rapidly decline between the ages of 35 and 50. At the same time, there's a little bit more of a gradual decline in testosterone, which does occur in females. And as a result of this decline in estrogen and progesterone in particular, there's a rise in LH and FSH, luteinizing hormone and follicle stimulating hormone. And interesting, there's also a little bit of a subtle decline in melatonin, which I think we have much more to learn about. And finally, there's a decline in a hormone called anti-Müllerian hormone, which is often thought to be a measure of ovarian reserve, and this too decreases and is often thought to be a marker of menopause in some settings. But I think the reason you can contrast that with potentially what's happening with males in the same age range is you look at what's happening with testosterone changes in males, as you'll see in that blue color, and it's a relatively gradual decline in testosterone. Whereas in females, you can see it's a pretty stark decline in that estrogen and progesterone. And I think this is why, because of this hormonal shift being so rapid, is really why this is a little bit more profound, I believe, in females in this age group than what we hear from our male patients. So what are some of these symptoms associated with menopause? There's many. I think we heard a little bit about hot flashes already, which is one of the most common ones we hear about and very disturbing to people when they're experiencing those. But there's also mood swings, sleep disturbances, irritability, headaches, difficulty concentrating, loss of libido, and joint pain. So it can be the gamut. And you look at many of these, and these are many symptoms that our patients with CF often describe in general. So again, it's really hard to tease out how much of this is menopausal related and how much is not. So what do we know about menopause and CF? And unfortunately, the honest answer is very little. I think that's a real call to action to all of us to really think about trying to study this more in the coming years. But there was a nice study done by Catherine Prokonik and Tracy Kazmersky out of Pittsburgh with a number of other centers. And this was actually a survey of 460 people, females with CF, ages 25 years and older, across 10 US CF centers. And of their 460 participants, 5 or 3% reported being perimenopausal and 7% postmenopausal. And amongst the symptoms that these people, particularly the ones that 39 that were peri or postmenopausal described, the most common ones that we saw, those occurring, first of all, almost all of them, 97%, reported some type of perimenopausal symptom. But the most common of those was waking up early in 83%, night sweats in 65%, stiffness of the joints in 65%, hot flashes in 58%, and vaginal dryness in 54%. So there's quite a high prevalence of this in the few people that were there, but you can see that it can be very disturbing to these people. What do we know about menopause timing? I think this is a question that we still have a lot to learn, but is often asked. And I know my patients ask me, when should I expect to experience menopause? And is it the same as the general population? I think the answer is we don't quite yet know, but at least in this study that I already mentioned to you, they found that the median self-reported age of menopause in this group was actually 48.5. And you can contrast that with what's known in the general population. It's actually 51 in the general population. So you can see that in this paper and a few others that have been reported out there, that in general, women with CF are thought to experience menopause 2 to 3 years earlier than women without CF. And what does this mean? It actually does have implications. So it has been shown that earlier onset of menopause can be linked to some adverse health outcomes. Those include cognitive impairment, dementia, worsening osteoporosis, mood disorders, sexual dysfunction, and actually increased overall mortality. So it's not a small thing to really address and make sure that we really understand if we should be counseling our patients and how to counsel them. And similar to the general population, if a woman with CF presents with early menopause, and early menopause is defined as less than 45 years of age, really we should refer that person for an evaluation by a women's health provider. It's warranted because, again, they want to screen for some of these consequences of early menopause, understand if that's what's really going on, et cetera. But that's when you really want to partner with your local OB-GYN. There are even obstetric gynecology doctors who have expertise in menopause. And so I think partnering with them for our patients is very, very important. So I think Sandy addressed this really nicely in thinking about what are the implications of hormones on lung health. And we really know very little about menopause and lung health in the CF population right now. But when you look at the general population and some of the nice studies that have been done out there, there is a couple that do suggest that menopause can impact lung function. And a couple of those, one showed that in general, there can be an accelerated decline in lung function. And interestingly, this was both in FVC and in FEV1. There's also been another study that showed more new onset asthma occurring postmenopausal, and in that new onset asthma, there was an increase in respiratory symptoms relative to other people with asthma. So it lends itself to wondering what's happening that may be leading to that. And I don't think we know the answer yet, but in the same study that I referred to you earlier, 30% of women who experienced menopause actually described that their CF symptoms worsened surrounding or after menopause. And so I think that's important to recognize that whether or not that's directly related to menopause or whether that's aging itself, we don't know, but it's something that we really need to watch for in our patients. Interestingly, in that same population, 3/4 of the participants who were using hormone replacement therapy did not report a change in their CF symptoms. So Sandy touched on this really nicely, and there has been data out there to suggest that fluctuations in sex hormones in females with CF can have implications to their lung health. Now, this has not been done in the setting of menopause, but more in reproductive age women, that first of all, it's important to recognize that as far as we know, levels of sex hormones in females with CF are similar to the general population. But there has been a few studies that show at times of higher estrogen levels that this is associated with inflammation and even increase in pulmonary exacerbations. Well, you'd say to yourself, well, then you would think that when they hit menopause and these estrogen levels are going down, that they should feel better. And I think we don't at all know that yet. We also don't know the implications of LH and FSH rising as that estrogen goes down. So I don't think the whole story is in estrogen, but it's at least interesting to know that there is definitely data out there suggesting an association. I think this question came up earlier about the implications of hormone contraception and how they may impact that. And there has been a few studies, including a very nice study published in the New England Journal about 10 years ago, looking at females throughout their menstrual cycles and finding that pulmonary exacerbations were associated with times of high estrogen, and in females who were on hormone contraceptive therapy, oral hormone contraceptive therapy, that pulmonary exacerbation risk decreased. So again, you would hypothesize based on that pulmonary exacerbations would decrease and pulmonary symptoms would get better post-menopause, but I really don't think we know that at all and definitely can't assume that without the data. So what else besides the lungs do we need to think about? So I think you heard that sleep is a big, big issue, and I think that is not just true in the CF population, but in females that experience menopause as a whole. And it's really one of the most severe symptoms that people face. It's exhausting to be tired at time. It's very frustrating to not sleep well. And actually, according to the National Sleep Foundation, 40 to 60% of menopausal women have sleep problems. And this really can be from all sorts of things. Some of it is thought to be from hormonal effects. Others are thought to be from the night sweats that females may experience at nighttime associated with menopause. Others are thought to be from reasons that can include depressive symptoms, stress-related phenomenon, et cetera. But I think that is something that we can expect to hear in a number of our patients with CF, and really have to think about how can we help them and support those symptoms that they're having. Other, I think, key issues to think about in the context of CF is bone health. I think, as we all know, that people with CF are already at risk for early bone loss and more rapid osteopenia and osteoporosis. And when you look at the variety of contributors to bone loss in CF, there's a number. They can span from poor nutrition, pancreatic insufficiency, vitamin D deficiency, diabetes, et cetera. But one of these circles on the bottom left that you see is actually sex hormones insufficiency in a variety of settings. But when you think about postmenopausal women, this is very well described. In fact, it's a time of rapid decline in bone mass. And right now, while we do have CF bone screening guidelines, these are not unique to menopause in any way. And in fact, they don't address menopause menopause in any way whatsoever. When you look at them, what we have right now is that you want to consider screening people with CF greater than 8 years of age with certain criteria. If you find a normal DEXA, you may want to repeat that every 5 years. If they're osteopenic, repeat every 2 to 4 years, or if they have osteoporosis, every year. You can see that there's really no details of what do you do in our aging population, or particularly in our postmenopausal females. So again, we have to really glean from the general population, what do we need to think about? And as I mentioned already, menopause is a time of accelerated bone loss. In fact, 20% of bone loss occurs in the first 5 years of menopause. So it's very important to identify this early. You can't wait till somebody's 60, 65, et cetera, to be thinking about getting DEXAs or being more aggressive about getting a DEXA screening. For those who don't know what a DEXA is, that's dual energy X-ray absorptiometry, and basically that's giving it's an X-ray test that's done to give a sense of what your bone mass is. And the thinner the bones are, the worsening their bone density is, and the more they're at risk for osteoporosis. So in the general population, when someone is postmenopausal, it's actually suggested that you get a DEXA scan every 1 to 2 years. We may want to think about, in our postmenopausal women, do we need to do this every year in CF? I'm not saying that we know the data or whether that's the right thing, but I think we certainly need to think about being a little bit more aggressive about our screening. When we think about treatments, it's really, again, similar to what we know about the general population currently, which is we want to encourage increased activity, weight-bearing exercise. We want to make sure their calcium and vitamin D is optimized. Hormone replacement therapy is a very good option, particularly ones that have estrogen in them. And then there's therapies such as bisphosphonates and actually denosumab, which is uniquely approved for postmenopausal women, that we should consider thinking about using in our females with CF that are postmenopausal. So other impacts of menopause are pelvic dysfunction. And I know I myself have had a number of my female patients really struggle with this, particularly in their late 40s and early 50s. But this really occurs that as estrogen and progesterone levels are decreasing, pelvic floor muscles become weaker. This can lead to a number of complications, some being urinary incontinence, others being prolapse, pelvic prolapse of different organs, painful sexual intercourse, decreased libido, and vaginal dryness. Some of the things you can think about is, at least for the vaginal dryness, that vaginal atrophy can be treated with local estrogen therapy. So if they have concerns about using oral or systemic therapies, that's a good option. And urinary incontinence treatment may vary. When you look at the urinary incontinence treatment, they can think about things such as pelvic floor strengthening, including Kegel exercises. Hormone therapy, as I mentioned, some of the vaginal creams or even estrogen patches may help with their symptoms and even bladder leaks. There are unique medications geared at treating urge incontinence or overactive bladders. And then there are these pessary devices, which you can see here, which are devices that really help hold up the bladder and are most helpful for stress incontinence. And finally, there's surgeries. And I can say I actually had two of my female patients in their late 40s who underwent surgery this past year for their significant pelvic floor dysfunction that was leading to urge and stress incontinence. And, it really became debilitating for them, where they did not want to exercise, they didn't want to walk around, they certainly didn't want to cough, and they actually had very successful surgical procedures. So, something to make sure that we're also making them feel comfortable about talking about those issues with us. So what are the treatments? My colleague Lindsay is going to get into that a little bit more. I just want to set the stage of what some of the pros and cons of some of these different hormone replacement therapies. But one of the keys to think about is the real benefit of hormone replacement therapy is it can improve quality of life during menopause. A lot of these symptoms I described, the sleep disturbances, the hot flashes, et cetera, it can benefit women. Now, maybe not all women, and of course with every medicine there comes risks and there's benefits. So the general mantra is to use the lowest effective dose of hormone contraceptive for the shortest possible time. But there are some contraindications to think about, and particularly some unique CF issues that you may want to consider. Some of those include females who have a history of venous thromboembolism, whether that's DVTs, pulmonary embolisms, or a clotting risk. That some of the estrogen-based therapy can potentially increase that risk, so you want to really be thoughtful and cautious about the therapy you choose in those people. Other who have liver disease, That's another area where you may want to sort of think twice about the type you use. And others with CF-related diabetes who have vascular disease is another group that it's been thought that you should use caution with hormone replacement therapy. But when you think about the different types, really there's combination therapies of estrogen and progestogen-based therapies and estrogen alone. And when do you want to think about these different ones? Well, both of these are going to help relieve menopausal symptoms, but in particular, and actually both will help improve mood. But there are certain things, for example, when it comes to the blood clot issue, that the combination can actually both can increase blood clotting, but there are certain things such as in the estrogen alone, there can be an increased risk of endometrial cancer. In the combination, there can be an increased risk of breast cancer with long-term use. So this again is not something that we're necessarily always thinking about as CF providers. And this is where if you partner with an obstetric gynecologist, and particularly someone who has expertise in menopause, you can talk with them and work together and think about what the right option is for your patient, giving them the information about your concerns, whether it's their liver disease or their history of DVTs, et cetera. So just to give you a little bit of information from that same study I quoted of the little we know about menopause and CF, in that study that I quoted earlier, about 24 of the people used estrogen therapy alone, 15 a combination of estrogen and progesterone-based therapy. And when you looked at the impact, I had mentioned to you that when it came to CF symptoms, about 42% reported worsening of their symptoms during menopause. But when you look at how many people had improvement of their symptoms when they started hormone replacement therapy, it was about 17%. So certainly not all of them, again, which is where I think we have to be cautious when we say this hormone replacement therapy is going to help you, because it may or may not, but sometimes it's worth trying if their symptoms are quite debilitating. I also want to mention, and Lindsay may be getting into this further, that in 2023, there was a non-hormonal menopause treatment that was approved by the FDA. It's got a tough name called fezolinetant, but this therapy actually works directly on the brain to impact the temperature control pathway and alleviate some of the hot flashes and night sweats. So again, for your patients that may have reasons they can't take hormone replacement therapy or are nervous about that in a way, this therapy is known to reduce the frequency and severity of hot flashes, help with some of the severe symptoms in menopause, and it actually was a randomized placebo-controlled trial where it proved to be better than placebo in a 12-week study. So another thing to think about, or to ask the OB-GYNs that you work with on whether this might be a good option. So I'm just going to end by one more piece of information that was in that study that I mentioned to you, and that was that 1% of the survey participants actually reported, again, only 1% reported discussing menopause with their CF team, despite at least 19% wanting to discuss the topic with their team. So we probably as a community are not yet doing the best job opening the doors for these discussions. So I think it's really important for us to think about this model where our CF care team needs to partner with either primary care doctors or subspecialists such as obstetrician, gynecologist, to make sure that we're really putting our patient at the center and ensuring that they have all the right resources to get their questions answered in the setting of CF, and that we're doing our due diligence to help them. So I'm just going to end with a few just highlights that I want to make sure you take home, which is that current reports suggest that earlier onset of menopause does occur in females with CF, and this can have implications on their future quality of life. Some studies do show worsening of CF symptoms after menopause, so it's something to think about when you're really, taking care of those 45, 50-year-old female patients and the things they're describing to you. We have to open the avenue for these discussions and partner with our colleagues who are experts in this field and evaluate what the best treatment options are in the context of CF. And that's really going to take more studies or databases, et cetera, to answer that in a thoughtful way. So I just want to acknowledge the Sharing Working Group, which is a sexual health, reproduction, and gender research working group that is really trying to tackle a number of these issues related to sex, gender, reproduction, et cetera. And then acknowledge my own team at UT Southwestern, who's always been an advocate for our patients and for me. So thank you for your time.
If anybody has any questions and would like to come up to the mic, If not, we do have some virtual after that.
Hello, can you hear me? Yes. My name is Ladina. I'm one of the CF Fellows at the Royal Brompton in London, UK. And actually, we just had the opportunity to present our poster on a survey we did on our cohort, or the whole CF Center, where we wanted to have a look at menopause transition in females with cystic fibrosis. And actually, what we found out is that at least in this cohort, those women had the menopause at the same age as the standard UK population, which is actually a good sign. So it was also 51 years of age. And yeah, so I don't know if you,
No, I'm so glad you shared that, because as I was describing with you, this is a pretty small study that I was quoting, and I think it really highlights the need for us to have multiple studies, large studies from other countries. So that's good to know. I mean, we may find, even if we reproduce this in a larger population in the US, maybe it will not be earlier, which is a great thing. So thank you for sharing that.
thank you.
Sure. Here's a question for you. My wife went into early menopause at 47. She had a very tough, often long cycles after her 40s. Is this common?
Tough, long menstrual cycles, I would assume. I think it probably varies. I mean, I am not a gynecologist that takes care of this regularly, so I can't say how common it is in the general population. All I can say is symptoms vary quite a bit. And I think there's a lot of confounders in CF2, and especially in unique individuals. There are some that have had to use steroids throughout their life for different aspects of their CF, and those can impact hormones, et cetera. But I can't say that I know how common that is within CF, but I know that symptoms vary quite a bit. That my suspicion is that's not rare, but unfortunate, it sounds like.
Did you have any participants who had worse issues after Trikafta?
Yeah, so that's a good question. This survey was really largely before the widespread use of modulators, so we didn't really have that ability to, given there was only about 39 people in general, we really didn't have the ability to tease out how Trikafta might be impacting that. And that's actually interesting to hear about the UK population, because I'm guessing maybe you did that survey post-Trikafta, is that right? So, I mean, that's really interesting. Is that the reason, or is it just another population, et cetera? So I don't know the answer from this survey, but, it sounds like we have a lot to learn in that area.
I'm going to ask another Trikafta-related question. Do you anticipate that with widespread ETI use, the average age of menopause for women with CF will be closer to 51?
I don't know. I guess it's all related, and we'll see. I think we also have to realize that for people who started Trikafta later in life, that may not change the course of their life when it comes to things like menopause right away. But for those who have the opportunity to start it at a young age, maybe so. I should certainly hope so, but I can't say that I know yet.
With regards to the DEXA scan, is there anything known about baseline bone density in CF? Is it different compared to individuals without CF, making females more at risk?
Yes, so in general, bone density is thought to be lower in people with CF. They are certainly at risk for osteopenia and osteoporosis. We don't yet know all of the risk factors, but having CF in itself is a risk factor. In terms of male-female differences, that we really don't know well yet. And I know that there are people working on that. Melinda Wu, for example, at Johns Hopkins is taking a deep dive into male-female differences in bone health. But I think we do know, just based on the general population, that risk of osteopenia, osteoporosis is amplified in menopause. So putting CF in the context of menopause, I think we really have to consider that a high-risk setting.
How does this impact women with cystic fibrosis that also have PCOS?
That's a good question. I can't say that. I'm probably not an expert on that to answer that question. I don't know if anybody else in the audience is, but I probably shouldn't even get into it because I don't have enough expertise to really be thoughtful about my answer. Anyone else? I know I see some agents out there, but you don't have to speak up if you're not sure either. Okay.
All right.
I think there's a different recommendation for HRT for women that have PCOS. So that's the only thing I really know. Yeah.
Thanks, Andy.
Thank you.
Okay, thank you very much.
Can I just say two more things? I'm sorry. Thank you so much, Raksha, for that really great presentation. One of the things that you talked about with lung health and estrogen declining, the thing about perimenopause, especially, well, the thing about perimenopause is that estrogen declines overall, but in the process, it's erratic. Estrogen becomes erratic in perimenopause. And this may, we don't know, but this may be one of the reasons why females have more frequent congestion and maybe worse symptoms, is that the fluctuation, the erratic nature of estrogen may be one of the reasons, rather than just the level itself or the decline in the level itself.
Yeah, that's a great point, Sandy. And I think actually even in the asthma literature, that has been shown a little bit. So you may be very right that there is a little bit of that that's occurring.
Yeah, and then the other thing I just wanted to say was the Menopause Society this year changed its guidelines to recommend HRT, or now they call it MRT, menopause replacement therapy, or menopause therapy, to think about prescribing hormone therapy earlier than usual, or earlier than it did before. And that the reason is that the bone loss that occurs in late perimenopause, like that decline, you spoke about this, Raksha, that there's this rapid decline right after you reach menopause, and 20%, I think you said, like the 2 years after menopause, being post-menopause, you have a rapid decline. You also have it during late perimenopause. And so the Menopause Society now is recommending that women start hormone therapy during that time. In other words, the first time they have vasomotor symptoms, they're telling, women now, get on it. And part of the reason is it can preserve your bone. It doesn't allow the rebuilding of bone, but it might preserve what you have better than if you're not on it. So anyway, so their guidelines have changed.
Thank you, Sandy. Next up, we have Lindsay Fitzpatrick. She's a board-certified clinical pharmacist practicing in the adult and pediatric CF clinics at the University of Kansas Health System. Additionally, Lindsay functions as the PGY1 residency program coordinator at the University of Kansas Health System Legacy Campus. She is actively involved in optimizing the role of pharmacy in CF care. We love our pharmacists, and does so through research, quality, improvement initiatives, and involvement in the CF community, both locally and nationally.
All right, thank you. I'm going to jump right in because we have a lot of content to cover in a short amount of time. And so I'm going to build off Raksha's presentation. And really this presentation started with looking at drug interactions, but we're going to have to dig into what those medications are that we're going to look at drug interactions with. So we're going to also look at some treatments. I have nothing to disclose. And kind of like I described, we're really going to jump into what are some of those treatments look like, both prescription, non-prescription, look at some herbal supplements that people will reach for these menopausal symptoms. We'll look at the drug interactions that may potentially occur with that. And then we also want to look at what considerations we have for our transplant population, as those medications interact a little bit differently. I wanted to draw our attention to the menopause guidance website that was created by the CFresh group. And one of the first things on that website is a list of questions that patients should be asking their CF providers and vice versa. There's 5 questions for each of the groups, and 3 of the questions that patients should be asking their CF providers actually deal with medications and how menopause medications may affect their CF medications. Similarly, what providers should be asking patients, or what the CF team should be asking patients, is, are you taking any over-the-counter supplements, or are other providers prescribing medications that we need to know about? So overall, I feel like this is a good indication that we really need to be understanding the patient's overall medication regimens so that we can be providing the best care. So taking kind of a transition to talk about treatment, we have both prescription and non-prescription, and we're going to dive into both. And in the prescription realm, there's both hormonal and non-hormonal, and Raksha touched on that briefly. And the treatment is really patient-specific and depends on what their symptoms are, how those symptoms are affecting their quality of life. It may depend on what their past medical history is, what their contraindications are. And so really the choice of treatment is very patient-specific. And so we're going to go into these two categories here. Starting with hormone therapy, both the Endocrine Society and the North American Menopause Society, which while I was creating this presentation changed their name and their website to the Menopause Society. So they have recommendations kind of looking at risk-benefit, and they favor treatment for women aged less than 60 who are within 10 years of menopause onset, have no contraindications, and have bothersome symptoms. So that is their overall recommendation. And then kind of looking at what those hormone therapies look like. There's many routes, doses, combinations, and really the choice of product, again, is patient-specific. So what do they cost? What is the strength? How can they get it? There's various estrogen formulations on this slide, with the 17-beta estradiol being most structurally similar to the estrogen that's produced in the ovaries. And a few key points that we want to talk about with hormone therapy. There is definitely a preference for low-dose topical vaginal therapy if it's prescribed for vaginal symptoms specifically. The treatment goal is always to use the lowest effective dose for the shortest amount of time. And really just a note about the progestogens, the indication for progestogen really is to prevent endometrial overgrowth and prevent the increased risk of endometrial cancer during estrogen therapy. So any female on estrogen therapy with an intact uterus should also be on progestogen therapy. I don't think you can talk about hormone therapy without getting a little bit into safety. And so the Women's Health Initiative studies came out about 20 years ago now. I think it was like 2002, 2004. And they were designed to assess primary prevention. So looking at the risk benefits of potentially preventing heart disease, breast and colorectal cancer, and osteoporotic fractures in postmenopausal women. These studies were not designed to assess the impact of menopausal symptom management. So I think that's a key point. These studies were terminated early due to the increased risk of DVT and PEs, coronary heart disease, stroke, and breast cancer in the combined hormone therapy group, and an increased risk of stroke in the estrogen alone group compared to placebo. Since their publication, there's been controversy on how the data was presented and which groups may still actually benefit from therapy. And some of those critiques really talk about the average age of the female patients in that study, which was actually 63. In comparison, it's been shown that women less than 60 are actually more likely to seek out treatment for their menopausal symptoms. To look at the benefit risk a little bit more closely for the women age 50 to 59, this graph I pulled from the 2002 North American Menopause Society position paper on hormone therapy, and it in itself was drafted from a 2013 Women's Health Initiative kind of assessment post those studies. The risks in red and the benefits in blue are expressed as a difference in number of events per 10,000 women per year. And really the importance of this graph is that red dashed line at the less than 10 per 10,000 per year mark. This line defines a rare event based on the frequency of adverse drug reactions. And so you can see while there is risk, all the risks are considered rare in this specific age group that was analyzed. So really kind of rounding out hormone therapy, Overall, these findings have really shaped how therapy is used in practice. The flowchart on the right is taken from the Endocrine Society guidelines on the treatment of symptoms of menopause. And really, again, their statement is the benefit of hormone therapy is greater than the risk in symptomatic women who have interest in hormone therapy and who are less than 60 years of age and within 10 years or 10 years since menopause who don't have any contraindications. So that kind of really is their overall recommendation. I want to move to discuss the non-hormonal prescriptions that are available for patients who maybe are unable to take hormone therapy or who choose not to. There's many non-hormonal prescription therapies that have been evaluated and found to significantly reduce the vasomotor symptoms in symptomatic women. However, there are only 2 FDA approved for this indication. So we have the paroxetine mesylate salt listed there, and then the new medication fezolinetant, which was approved in May of 2023, and is a newer class of medication that specifically targets the neural mechanisms that cause the vasomotor symptoms. The non-FDA approved non-hormonal prescriptions recommended by the Menopause Society are listed on this slide. And you can see we have a couple SSRIs, there's a couple SNRIs, gabapentin and oxybutynin are listed there. All are studied to target vasomotor symptoms specifically, but could have benefits in other menopausal symptoms such as depression and the sleep disturbances. A few comments to note when I was kind of looking at this is not all of the SSRIs are listed. So we probably see sertraline as one of our most common SSRIs. And so sertraline and fluoxetine, for example, have shown trends toward improving vasomotor symptoms, but were not statistically significant and thus not recommended in their guidance. Gabapentin has been studied at actually higher doses, up to 2,400 milligrams a day, and has been shown to be as successful as estrogen in relieving hot flash severity scores. But gabapentin at that high a dose really does have a lot of side effects and can minimize or can kind of limit how it's used. A few other medications that I was surprised to not see on their recommendations that had been used in the past or we've seen in the past include pregabalin and clonidine, and those are no longer recommended due to lack of evidence and their side effect profiles. I created this slide kind of messy because that's how I felt when I tried to find the over-the-counter and herbal medications that are used for or claim to be used for menopausal symptoms. I think one of the things to note about herbal medications is they are not FDA approved. They're directly marketed to consumers, and they can claim to relieve any number of symptoms related to menopause. So I think that's really the key point. I tried to gather the most popular ones by looking at some menopause websites that maybe patients would visit, the National Institute of Health, and then kind of just strolling down the aisles of the pharmacy and seeing what is actually out there for patients to pick up. So this is kind of a smattering that we're going to look at. This is by no means all of the herbals and over-the-counters that are available. I do think it's important to note that the Endocrine Society, the Menopause Society, the National Institute of Health all have statements recommending against the use of herbal supplements for the treatment of menopausal symptoms. But despite that, they're really quite popular. There was a study in 2013 that reviewed several surveys assessing herbal medication use in menopausal women and found that up to 50% of respondents reported herbal or alternative remedy medication use. Interestingly, over half of those respondents didn't disclose their use to their healthcare team. So I think that's a really important point that we need to be asking about that in our clinic visits. So kind of getting into why I was actually asked to present was looking at drug interactions. So how do drug interactions happen, and do these prescriptions or herbal medications affect our commonly prescribed CF meds? So let's first look at how those might occur. I wanted to focus on 2 types of drug interactions for our discussion today. We have our pharmacokinetic and our pharmacodynamic interactions. And the pharmacokinetic interactions involve changes in absorption, the distribution, metabolism, or excretion of one medication due to the presence of another. So that's really kind of what we're looking at. I highlighted metabolism there, as that really is a key place for drug interactions to happen. And the cytochrome P450 enzymes, or the CYP enzymes, which is a family of enzymes found in the liver that play a role in metabolism, actually metabolize 70 to 80% of the drugs on the market. So it's really a kind of a target for drug interactions. A change in any of those 4 factors may actually result in an increase or decrease of drug concentrations, which thus can change the effect of your drug and or the side effect or toxicity profile. Kind of specifically looking at metabolism again, this can occur when the CYP enzymes are inhibited by a specific medication, which can lead to a higher drug concentration than is desired, or the CYP enzymes can be induced, which actually leads to a lower drug concentration than desired. Our pharmacodynamic interactions are a little bit simpler. They involve interactions or changes in the effects of drugs due to their combined actions. So this could be a synergistic effect or an antagonistic effect, and can be both from their designed intent or actually a combination increasing side effects. So applying those mechanisms to our commonly prescribed CF medications, we can see that the CFTR modulators are susceptible to drug interactions involving the metabolic enzymes. And ivacaftor is actually the most sensitive CYP3A substrate among the Alex-Tez-Iva components, with about 98% of the drug fraction being metabolized by the CYP3A system. In addition to hepatic metabolism, both ivacaftor and lumacaftor have an influence on the CYP3A enzyme itself, so they affect the concentrations of other drugs utilizing that specific pathway for metabolism and excretion. Ivacaftor does inhibit that CYP3A enzyme, and the lumacaftor induces that enzyme. Azithromycin does go through hepatic metabolism, although minimally, and has been shown to be a weak substrate of CYP3A4, but it neither induces nor inhibits CYP3A4 activity. And our other common CF medications, including enzymes and inhaled medications, have minimal systemic absorption, and so we're not going to focus on them specifically for our presentation today. So this is a busy slide, and I want to orient you to it. So across the top, or what we're looking at, are drug interactions between our common CF medications used to treat menopausal symptoms, and then the commonly prescribed prescription medications prescribed for menopausal symptoms on the left. The metabolism interactions that occur between the medications on here that are listed are related to lumacaftor's ability to induce that CYP3A4 enzyme, and thus decreases the concentrations of hormone therapy, citalopram, and escitalopram. And I know this interaction is likely of less significance due to the development of newer modulators, but it still may come into practice, so I wanted to highlight that here. The synergistic interactions seen most commonly occur with azithromycin and medications that also have a risk of QT prolongation. And so those are listed all on the right with the azithromycin column. And then the final interaction listed in this chart occurs with the CFTR modulators and fezolinetant. And this didn't necessarily pop up on the interaction checker, but when you read fezolinitant's medication kind of package insert, it does talk about the potential to increase AST and ALT lab values, which we know also comes into play with our CFTR modulators. So I felt that was important to note. I also wanted to kind of point out the synergistic interactions do not necessarily preclude use of those, but it's really just something to be aware of for monitoring or when considering someone else's, the rest of their medication profile or their past medical history. So looking at herbal medications interactions, really the mechanisms of drug interactions for herbal meds is the same. But they're often not based on rigorous research. So most herb-drug interactions identified in current sources are hypothetical. They're inferred from animal studies, cellular assays, or even by other indirect means. They definitely are not as reliable as what we have with our prescription medications. For any pharmacists in the room, this is a very familiar reference. This is actually the Natural Medicines Database, and it's what we specifically utilize to review both the information and interactions of herbal medications that our patients bring to us or talk about in clinic. It uses sort of a stoplight rating system to define drug-herb interactions, and really, as mentioned earlier, these interactions are often not based on rigorous research, and so they're classified as minor, moderate, and major, and these levels are determined by both their likelihood of occurrence as well as the potential severity of the interaction. So we're kind of going back to a chart that we looked at with our prescription medications. So again, our CFTR modulator azithromycin is listed at the top. And this is going to be 2 slides long, but these are the common herbals that I was able to pull and kind of look at what those drug-herb interactions might look like. There are both metabolism and synergistic interactions listed on this slide. And really what I want to highlight is the wording theoretical and unclear. And so overall, the interactions do appear minor on this slide, but there's always a risk-benefit discussion with the patient when they want to talk about utilizing one of these herbal medications. I do want to note the comment on the black cohosh, as this is the most common herb that I ran into as being recommended for the treatment of menopausal symptoms. And this is not, again, necessarily a drug interaction, but cases of liver damage have been reported with its use without really a defined frequency. And so the Menopause Society and National Institute of Health really note it on their half, and they want patients and providers to know about those. Continuing on this chart from the previous slide, you're probably drawn right to the red right at the bottom there. So red with a major interaction, which is with St. John's wort. It is a known inducer of that CYP3A4 enzyme, and so it will increase the metabolism of all of the CFTR modulators, and so their use is not recommended together at all. So no dose adjustment whatsoever, just not recommended. The other metabolism and synergistic interactions listed on the slide and you can see again the wording theoretical and unclear. So again, really a risk-benefit discussion is always warranted with these herbals. Listed under the chart is a sampling of the herbal medications in which I could not find a drug-herb interaction with the CFTR modulators or azithromycin with the database that I utilized. One important counseling point I wanted to bring up when discussing herbal medications is the possibility of combination products. So the 3 products on the slide are all manufactured by the same company, marketed for menopausal relief, targeting many of the same symptoms across the 3. But they're both combination and single compound products. So it's really important to be specific with patients when they discuss wanting to use an herbal medication, even if they say a brand. That might not give you enough information on what is actually in that product. We often ask patients to take a picture of the supplemental facts and send it to us via MyChart or email, or even to bring it into clinic so we can really understand what's actually in the product that they want to utilize. So the last thing I wanted to talk about are some considerations for our post-transplant patients. Firstly, this actually may become even more of an issue of discussion as transplanted patients are prone to premature menopause and thus may seek out medication for symptomatic relief earlier than our general CF population. Secondly, the consideration for drug interactions is heightened even more in this patient population, as medications utilized to sustain the transplanted grafts really have narrow therapeutic windows, especially our calcineurin inhibitors. And lastly, hormonal therapy is not contraindicated in this patient population, but there is a need to look closely at comorbidities and past medical history, as the contraindications and cautions for hormone therapy may be more common in our transplanted patient population, specifically kind of looking at diabetes and the VTE. And I think with that, I can take any questions.
Do we have any questions from the audience?
Can I ask a question?
Sure.
So during perimenopause and postmenopause, metabolism of women decreases, just like that's why there's adiposity and weight gain, et cetera. And so I'm wondering how that slowing of sort of our general metabolism, both CF and non-CF women, affects these kinds of interactions. Maybe the dose of hormone therapy. Do you know?
You know, I didn't come across that necessarily in any of my research, but I think what you're getting at is the absorption time, or the absorption of the medication specifically, and how much medication would be in the system. So I don't know if that's necessarily a drug interaction, but also may not specifically affect just premenopausal women. It may be in any kind of gastric slowing, but I don't know specifically that answer.
Okay, thank you so much. Yes, that is exactly what I was asking.
Did they take your microphone away? Oh.
So I work in a CF adult clinic and with a lot of female patients. Would you say that herbal supplements are not considered like dangerous because they're marketed like natural, and that's why our patients do not think of disclose it to us, and when we find out, they will say something like, "Oh, it's only ginger," or "It's only collagen." So there's always the "only" in there. So would you think the marketing is really important in there?
I do believe that when we've had a lot of patients, not specifically for menopausal symptoms, bring in just recently, they want to try herbals for a variety of reasons, and they think they're just buying this. And so we've really had to kind of dig down and ask, and we'll actually pull up that interaction checker in the clinic with them so that they can see what's actually going on, and it may be minor and that's fine, or there may be 5 things that pop up, and so that they can actually see this may be affecting my full therapy. Mm-hmm. I do think the marketing is tricky.
Yeah, thank you.
So we have an online question regarding paroxetine. FDA approved because it was particularly effective compared to other SSRIs, or was it more studied and thus more readily approved?
The paroxetine, it's even a specific salt. It's like the paroxetine mesylate salt. So I believe it was specifically studied as that salt at that dose for symptoms, for menopausal symptoms or vasomotor symptoms. And I just don't think the others have put in the time or that money to complete those studies.
From a pharmacology perspective, is there any potentially meaningful use of progesterone alone for HRT, for bone health, or symptom reduction for people with CF at risk for clots?
I don't know if I have the expertise for that question. I was like, do you?
I don't know that I have the expertise, but the one thing I will say is long-term progestin only use is associated in some scenarios with bone loss as well. So, so if somebody, more of that is in the oral contraceptive therapy world, but as a result, at least from oral contraceptive therapies, people don't recommend that if you have osteoporosis or at high risk for osteoporosis, not to use progestin-only based contraception. In the hormone replacement world, I'm not sure if that is the same, but at least, that's something to think about.
Great, thank you. Okay. So our next speaker is Summer Love. Summer lives each day to the fullest. She was diagnosed with cystic fibrosis at 11 months of age in 1980, when the outcome of the disease was very bleak. Today, Summer's now 45 years old, facing many of the issues our previous speakers touched upon. Summer has made it a priority to raise awareness, educate, and give hope to all of those in the CF community. Summer created Love to Breathe in 2001 to help further educate and raise awareness about cystic fibrosis and spread love with every breath she has. She knows she can't fight CF alone and knows that without her support system, she wouldn't be where she is today. Her support system keeps her going and continues to help fuel her fight. And she loves her pug. Pug power. So thank you, Summer.
Thank you so much. Thank you for that introduction. Hi, everyone. I'm so honored to be here and speaking on a topic that I am very passionate about. I love that women's health is being recognized more and more in this space. I have always believed that hormones have played a pivotal role in my CF health. Throughout the years, I've always been able to tell when my period was going to start because I would have hemoptysis right beforehand. There definitely needs to be more research done in this space so that next generations can be more equipped to handle these changes. Never in a million years, or I guess 45 years, did I think I would be presenting about menopause, but here we are. I love that the subject is getting talked about more and more because nobody talks about this. And whether we like it or not, menopause is inevitable. When I was asked to speak today, I had no idea what it would look like, what I would talk about, or even how I would go about it. But I knew that I needed to say yes. I am not new to public speaking. In fact, I'm a big believer in the power of sharing your story. And I do share my story every chance that I can. But today is the very first time I have shared so openly and publicly about this specific part of my story that has profoundly impacted my life. It has been an incredibly wild journey that I have been on these last 5 to 6 years. In fact, these last 2 years have probably been the toughest years of my life. Living with CF and having advanced lung disease has made me hyper aware of every single cell in my body. So when my peri-menopausal symptoms became problematic, I pretty much thought this was it. My time was up. I had no idea what was happening to me. I was losing my mind. So I feared the worst because I guess living with this invisible clock over your head can do that to someone. However, thanks to amazing medical advancements, a ton of hard work, I'm still here. And I get to experience the world of menopause. I'm gonna say that again slowly because I have to remind myself often. I get to experience menopause. I am so grateful to be growing older because I know that aging is a gift denied by far too many. But with that being said, it has certainly been a challenging couple of years. Thankfully, I am in such a better place today than I was even 6 months ago. And every day, I'm learning new ways to tackle this challenging journey. Looking back at what I know now, I would probably say I embarked on this journey back in 2019. I was so emotional that year. At the time, I thought it was because 2019 was such a huge year for me. I was awarded the Alex Award by the Cystic Fibrosis Foundation. My pug babies, Oscar and Lily's failing health, turned into me making the toughest decision of my life. They both passed on May 9th at the age of 14. I turned 40, which was a huge milestone. And in November that year, I started Trikafta. I would cry when I was happy. I would cry when I was sad. I remember sitting in the airport and a Disney commercial came on and it opened the floodgates. And trust me, I am not a crier. My emotions were all over the place that year. Little did I know that this was the start of perimenopause. Then 2020 hit. And we all know what happened then. Although I feel like I really thrived in 2020, not being faced with decision fatigue, weighing risk versus reward, worrying about if I was going to be around sick people, missing out on activities because no one was actually doing anything. Everyone was living the CF life, but then people started getting back to real life. And I was still being so very careful. And I started noticing my body changing. And at the time, I thought, this must be Trikafta changing things. And I'm sure that was the case. But not only was Trikafta changing my body, so were my imbalanced hormones. And on top of that, I was dealing with the effects of COVID and isolation. It was the perfect storm. In 2022, I was hospitalized, and I have never been more stressed. It ended up being the most traumatic hospital stay of my life. Probably because the lack of estrogen in my body and the high cortisol levels made it nearly impossible for me to process any stress. Stressful situations have now become a whole thing, and I couldn't deal with it. The way I get overwhelmed so easily now can be so frustrating. Complications from that hospital stay, and then being diagnosed with mild pulmonary hypertension and a new chronic sinus infection that I cannot seem to kick, threw me into a tailspin. My anxiety after that hospital stay was at an all-time high, and I didn't know how to cope. That was the peak of my perimenopause symptoms, and it was tanking my health and well-being. I was having heart palpitations, night sweats, low heart rate, high heart rate, insomnia, tinnitus, joint issues, hot flashes, brain fog, constipation, frequent urination, blood sugar lows, high cholesterol, fatigue. I was dizzy all the time. I was freezing all the time when I usually always run hot. I was bloated after eating anything at all. My oxygen sats were not great. My period would come and go. I would easily get frustrated, annoyed, grumpy, irritable, you name it, I was experiencing it. I felt like I was unlocking a new menopause symptom daily. I saw a cardiologist. I had a sleep study. I was seeing so many doctors and having so many tests done, trying to find any answers. I found out my FSH levels were showing postmenopausal, but I was still having my period. Nothing made sense. I was desperate to find solutions to help me manage all my symptoms. I was meditating, doing yoga, reading, journaling, taking walks, catering to Tulip, my very sassy pug's every need and want. I turned off all notifications on my phone. I was doing all the things to try and get my anxiety under control. It got so bad. I remember texting my amazing CF doctor, Lori LeClaire, one night before clinic saying, I need to come see you. I don't need PFTs, I just need to see you. She didn't even ask any questions. She made room for me to come in, and I remember sitting in that appointment crying and saying, I am trying everything, I don't know what else to do, and she just listened to me, and she was so supportive. After talking to her that day, a weight was lifted off my shoulders. I thought maybe talk therapy might be helpful, so I tried to find a therapist I could talk to, and in my quest to find one, I started talking more and more about perimenopause and my anxiety. And I found the more I talked about it, I wasn't alone. I actually never found a therapist that was taking new patients, but I felt like me just talking about it more and more to anyone and everyone was so beneficial and was helping me heal. I saw a menopause specialist and was hoping to get on hormone replacement therapy, but was only offered an IUD or regular birth control at this time, which is not something I want to do. So it was back to the drawing board, more research to see how I could help my body naturally. My body has completely changed over these last couple of years. I weighed the most I've ever weighed in my life. My blood pressure was trending higher and higher, so high that I now say I have blue gown syndrome. It's also known as white coat syndrome, but in the CF world, we have that blue PPE that's covering those white gowns. So naturally, I changed the name. I knew I had to make some big changes in my health. I have been vegetarian for the last 15 years, and all my research kept saying over and over to up protein and fiber intake. So I'm a carnivore now. My diet has completely changed. It's not perfect, but I eat mostly all whole foods and 60 to 100 grams of protein and 20 to 40 grams of fiber a day. I eat way too healthy, and I love meat. I don't even know who I am. I also gave up all artificial coloring and all added sugar this year, with the exception of dark chocolate. And that is also new to me because my entire life, I have never liked chocolate, and now I love it. I definitely won't deny having a treat or some gummy candy here and there, but gone are the days where I could eat 5 packages of fruit snacks and ice cream daily. I have even gone as far as eating sardines for those extra omega-3s. Hormones are so wild and have completely changed everything as I have known it. I have also had to change up all my supplements and vitamins and have added in some natural remedies to help with my perimenopause symptoms. Thankfully, I can text my amazing CF pharmacist, Dave Young, to make sure nothing will interact with Trikafta. Never in my life did I ever think I would rub a natural progesterone cream on my body made up of yams, but here we are. Exercise also has been so important during this as well. In 2020, I started walking outside, and I have loved being able to do that. Movement is key for both physical and mental health. I'm currently dealing with sciatica issues right now from a herniated disc that has now turned into some sort of gluteal tendinopathy, and this pain is like nothing I have ever experienced. And in my opinion, I'm pretty sure it's all related to perimenopause. Because it all started in May when I was 100 days in of no period. I even had a countdown on my phone. I was so excited. I made it 100 days. Only 265 more days to go. And then, sure enough, 2 hours later, that day, I got my period. I was talking to a friend my age the other day, and she had no idea you had to go an entire year, no period, before you were considered menopausal. She didn't know because, again, nobody talks about it. After that 100 days, my period was every 2 weeks for a while. And right now, I'm currently back on the countdown, manifesting that this will hopefully be that final stretch. Okay, so anyways, getting back to exercise, see, that right there is a perfect example of menopause brain. So when I'm walking, I'm carrying a 10-pound oxygen tank on my back, which I'm gonna guess is not helpful for my herniated disc. So I have started putting my oxygen in Tulip's stroller, which has been really helpful. Just last week, I was finally able to walk a mile again, and I haven't been able to do that since May. Baby steps. I stretch for about an hour every day, along with some hand weights, to hopefully keep my muscles healthy and active. Concentrating on strength and resistance is a favorite form of exercise for me. It's the one constant that I can do at any lung function. And it's especially important for those of us with advanced lung disease, or as I like to call it, established lung disease. I try to keep my lungs as healthy as possible because I do feel like my mucus production increases before my period and my asthma symptoms worsen. For example, following that 100 days, my lung health plummeted, and it threw me into a CF exacerbation. I had to do round of inhaled antibiotics and steroids. My oxygen requirement increased, and I was back on oxygen 24/7. It took my lungs a couple months to bounce back from that setback. Earlier, I had said that I am in such a better place than I was even just 6 months ago, but I didn't get here alone. Having a support system is so important when it comes to facing any battle, no matter the size. I am blessed beyond measure to have the support system that I do. Talking more about perimenopause and recognizing the hardships has helped me cultivate a community of amazing women who are also going through this. I am so grateful to Sandy for being a sounding board time and time again. And the biggest blessing has been having a bestie go through the pause journey with you. Many of you may know Marissa Bencha. She has been my saving grace. Going through this challenging time together has been such a blessing. Now we're at the point where we just text each other a random symptom and we both are like, yep, check. I'm not sure if we've completely scared Casey White or prepared her for what's to come. But as Marissa and I have been dealing with this, Casey has been cheering us on every step of the way. I am just so very grateful that I finally feel like I have a handle on all of this. Do I have everything figured out? Absolutely not. Will I still be sent into a tailspin in the near future when I'm stressed or overwhelmed? Yes, absolutely. In fact, planning this presentation now and reliving these last couple of years actually had me feeling a bit overwhelmed and anxious, which leads me to believe I still have work to do to heal from all of the trauma this journey has caused. Every day, I am learning new ways to navigate all of this. So hopefully, when the next stressful situation arises or a new symptom pops up, I'm better equipped to deal with it. In the meantime, I will continue to keep talking about it to help normalize the menopausal journey. In fact, I was just talking about it with the woman who was loading my groceries. If you're going through these changes, I encourage you to share your story. Talk about it. Advocate for yourself and do your research. I truly believe that we can normalize and change the narrative surrounding hormonal health for generations to come. Not to mention, you just never know who you will inspire or the impact you can make along the way. Thank you.
Does anybody have any questions for Summer?
Oh, thank you, Summer. That was awesome. I just wanted to point out something that some symptoms that Summer raised while she was giving her story, and that is joint pain because of more inflammation, also just the hormonal changes that create inflammation. And what was the other one? I'm having a brain fog moment. Oh, anxiety. Yeah, anxiety. So mood changes and cognitive changes. Those are just as important as any other symptom. So thank you for raising that.
Yeah, of course.
So we would like to thank all of our panelists for helping and participate with us today. We would like to thank you all for joining us, and a special thanks again to all our CF community members that help share their information with us so we can learn more as we go on this journey. We hope that you have learned something valuable, something you could take back to your own care team, and please enjoy the rest of the conference and have a great day.